Today we're going to talk about sugar surfing, which is not a concept or a name that I've made up, but it's actually a book. And I want to go over a few concepts about how to use this method for specifically for patients that use basal bolus insulin and are using a continuous glucose meter. So just to outline, the first is that we're going to be reviewing the methods to manage blood sugars, traditional methods versus this new concept of dynamic management. We're going to review patterns of blood sugar variation and insulin actions, and then I want to go over some basic concepts that Dr. Ponder, the author of the book Sugar Surfing, goes into great detail in his book. And so I wanted to thank Dr. Ponder and give credit to him for almost all the images that we'll be using in this section. So the basic ways of controlling blood sugars in patients that have diabetes are static versus dynamic methods. So static methods are things that people may be familiar with, are insulin sliding scales or the use of algorithms like carbohydrate counting and correction factors, which have their place and have been used for many years. But for patients that have used this in the past, everyone knows that it's not perfect. And with the advent of continuous glucose meters, this concept of continuously acting upon your sugars has become important, which is outlined in the book Sugar Surfing. So the important thing to know before you deal with the continuous glucose meter is how your insulins work. So it's dependent on both, every insulin you use is dependent on, has a outcome based on how effective the insulin is, or the relative effect of the insulin, which is on the y-axis, and then how long the insulin is going to act. And this is going to be a little bit different in everybody, but the basic concepts are there are very rapid-acting insulins such as Lispro, Aspart, Apidra, commonly known as Novolog, Humalog. So these are insulins that are in and out of your system within 2 to 4 hours and have an onset of action somewhere between 5 to 30 minutes, depending on what type of insulin you're using and other factors that are specific to a person. There's regular insulin, which is an older insulin that takes a lot longer to kick in and lasts longer. And then there's NPH insulin, which is what used to be a basal insulin, or considered basal insulin still, but has a peak at around 4 to 6 hours. And then there's long-acting insulins, such as Glargine, Detamir, and Degludec, also known as Lantus, Levemir, Tresiba, Toujeo. There's several different names of brands for these medications. And those are supposed to last at least 20 hours, 24 hours or more, and have a much flatter curve, which becomes important when we talk about the concepts of basal bolus. So if we look at this diagram, which is showing on the left-hand y-axis, general what the blood sugars may be. On the right-hand y-axis, when we review the insulin, you'll see the effective insulin. And then at the bottom, you see BLD, which is reflecting breakfast, lunch, dinner, when you go to bed, and then you start over again the next day. What should be happening, or what generally happens in a patient that does not have diabetes, is that the blood sugars go up and down a bit with meals and eating. And if you look at blood sugars in people that don't have diabetes with continuous glucose monitors, you see there's still a lot of variation, which is maybe surprising to people, but this is generally the concept. So overnight, when you go to bed, your blood sugar should stay flat. So, and then you wake up in the morning with about the same sugar, plus or minus 20 or 30 points. So in diabetes, blood sugars generally run a lot higher. And so after meals, the blood sugars rise much more than they should. And specifically overnight, the sugars will continue to rise. So if you go to bedtime, you go to bed with a certain sugar, you'll usually wake up with an even higher sugar. This is assuming you're not on any medication. And that's generally due to gluconeogenesis. This is the fact that the liver has 3 or 4 days of stored sugar in it to feed your brain at night, for example, when you're not eating. But in diabetes, that sugar is stuck in the blood, and continues to rise because the liver is continuously pushing out a little bit of sugar all the time. So even if you didn't eat for 3 or 4 days, your sugars, if you had diabetes, would continue to go up. So the first concept here is basal. So when we give you long-acting insulin, we're giving you what we call basal insulin, and the goal there is not to normalize your sugar, but to flatten your sugar, or to get what we'll call later a shelf. And so the biggest, most obvious place to look at this is what happens overnight. So our goal with long-acting insulin is to keep your overnight sugars flat. So whatever blood sugar you go to bed with is the one you should wake up with, plus or minus 20 or 30 points. But notice that the spikes in sugars that occur after meals or snacks are not fixed or should not be fixed with a long-acting insulin. Although some doctors will treat patients with higher doses to accomplish that, but there are other downsides, such as a very high risk of low sugar reactions overnight. So the way we treat these high sugars in the day is to give you rapid-acting insulins timed in some fashion just prior to meals or just after if you are using a continuous meter. And if you do this properly, in this example, you've eaten 3 times in a day, it should control your sugars in a way that makes it more closely aligned to what it would look like if you did not have diabetes. Now, the ways in which you do that are static methods, which I'm not going to go into in this video, which are sliding scales and basically saying, okay, well, if you dose a certain amount of insulin based on what your blood sugar is prior to a meal, you should get a desired outcome. Or if you're using carbohydrate ratios, if you're eating a certain amount of carbohydrates, we're saying take a certain amount of insulin. The problem is there's so many variables, so we're kind of going to throw a little bit of that out and talk more about how to use a continuous meter. So a continuous meter, hopefully you're aware of what these are, but if you're not, these are a method to track blood sugar levels all day and all night without pricking your finger all day, all night. And these take regular glucose measurements every 5 minutes or so, or sooner, 24 hours a day. Now, once you're using this, it's a lot of information, and so the question then becomes, well, what do I do with this? Traditionally we would say dose insulin, short-acting insulin, 5 to 10 minutes before eating, and don't dose it if you're not eating. Well, if you're on an insulin pump, the same concepts apply. You would bolus insulin prior to meals in traditional static methods. But with the dynamic methods, we can use this information that's continuously being thrown at you to make decisions on the go, kind of like driving a car. So making decisions continuously to get from point A to point B. So also the ranges that people should desire on their glucose meters are variable. So it really depends on a lot of factors which should be defined by your doctor. And those factors are so numerous, it depends on your age and how you respond to insulins and your ability to respond to lows and high sugars. And so please talk to your doctor about that. So the basics of this dynamic method of treating sugars is called, which we're going to call sugar surfing from here forward, is basically to identify patterns, then understand if this is significant to the patient, and that's a subjective thing, and then how to respond properly and how to follow up on this. So I'm going to briefly go over some of these concepts, but not in exhaustive detail, because this is not a recipe, but this is more of a process that needs to be followed over time to understand your CGM continuous meter. So the basic patterns that we're going to review are the things that you'd want to, the basic patterns that you'd see on a glucose device should be looked at every 30 minutes to an hour, and you should be staring at it and deciding, what should I do with this information, because it's right in front of you. So we're going to review the concepts of a shelf, which is where your blood sugars are flat for a period of time, just like we talked about with basal rates overnight. Blood sugars overnight could be a shelf. If you don't eat during the day, you can have a shelf. So there's a plus or minus 20 or 30 point uh, 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 optimal range, and that's what a shelf would be. So if you're over a 1 hour period, you're noticing there's not much variation. That's what a shelf would be. Delta is a variation in your blood sugar where it starts to rise, and we need to figure out why that is, and then make a decision on if we should do anything about it. Then there's drops. Drops are the opposite, just like the name suggests, that you're dropping over time, and whether that variation is within or outside of your target ranges, which are defined individually per patient, is when you decide on an intervention. So, an important concept is that you may be in a normal range on your during a delta or drop, but you may or may not treat it with either food or insulin or activity. Those are your tools here. So, a big concept is that you might need to give yourself a little bit of insulin, even if you're still in a normal range, if you're rising or dropping, where there's a delta that's significant to a specific patient. And then, so the concepts of acting on something are a pivot, which can be done with insulin. In this diagram, you see that the insulin will bring your sugars down, of course, or you could use exercise as a pivot to bring your sugars down, or a carbohydrate pivot. Or there are things that you can't control, like stress, which cause your sugars to rise. So there are pivots to bring you down, and there's pivots to bring you up. You should also be aware of something called an inflection and lag. So inflection means that there's a lag period between the intervention, whether it's insulin, exercise, carbohydrates, stress, from when it occurs to when you'll see a change on your in your actual blood sugars, which will be reflected on your meter, and that inflection point is important to take note, and that's going to be different in everybody. So each patient will have a different response to these activities. So just to go over a couple things here, if you're getting the proper amount of basal dosing, it should look like this diagram here, which is showing time at the bottom and blood sugars on the y-axis. Basically, blood sugars, the goal of a well-set basal rate is to be pretty flat, and this is the concept of a shelf. And whether this is given to you by a pump or basal injection of insulin like Lantus or Levemir, it's a steady state of keeping your blood sugars within 30 points. And it's important to look at this every so often. And so one other thing to know is, well, you should start to look for a drop. So every hour or so, you should be looking and seeing if you're starting to drop. Now, one question is, what do you do if you're dropping and you're well over or above your target blood sugars, which again is defined by individual circumstances and with your doctor. So in these examples, you see here the patient starting in the 200s at the top diagram and dropping to the 190s, the second one in the 120s and dropping to the 90s. And this is, and in the third example, 100 into the 70s. You notice this is over a 1 hour period. The question is, should you act? And the acting would involve, well, do I need to do something to bring this up or not? And it really depends on what happens over time. So patience becomes important. And over an hour or so, you want to watch this as long as you're not in danger of running too low or getting a symptom from that. So at some point after the drop, you'll start to see, after you're watching it, you're going to be looking for an inflection when you're arriving to your blood sugar, your lower blood sugar limit, which again is, defined. Your limits or your targets are defined by you and your doctor. So in these examples, in this diagram here, you're seeing that the patient is viewing this, and one option is to take a pivot dose of insulin because your blood sugars start to inflect and rise upwards. So if you see that, insulin would make sense there. And note, if you had the patience to wait, great. But if you hadn't, you may have started eating too soon or done something to try to bring that sugar up, and it would have come up anyway. So give yourself time to watch what's happening on a drop. A second is just to take the drop and see what happens if it flattens out, and let it happen. And that would be nice, and if you don't have to do any intervention. Other options are to either just watch it and make decisions on the fly, glancing every so often. And a last option is to give yourself some carbohydrates to bring your sugars up if you're dropping too quickly. So there's a concept of rate of drop and rapidity of drop, and the significance really depends a lot on individual patient circumstances. So patience again is very important. So in this example, we're reviewing the concept of this accelerator and the brake. So you need to know a lot of information about the food you're eating. Is it a fast carb, a slow carb? So the concept of glycemic index becomes important. For example, not all juices are the same. Apple juice has a low glycemic index compared to pure grape or cranberry juice. So the rapidity at which, how rapidly your blood sugars go up with a carbohydrate can depend on your body and the glycemic index. So knowing the speed or how fast your carbs will affect your sugars will help you make better decisions on giving yourself insulin. So in this example, the patient has a relative shelf at the beginning, but then there is a delta that is occurring, and they give themselves a small amount of insulin, 4 units in this example, and then they start to drop. They watch the drop over a period of time, and if they are you can use, if you get a little nervous about dropping low, you can use a break of 4 grams or a small amount of carbohydrates to cause an inflection to flatten out and get back to steady state or a shelf. So remember, glancing at these shelves when you're in your range is important. Whether or not to glance every hour or every 30 minutes depends a lot on how significant the value of the sugar is to a patient and what symptoms you're having. Remember, shelves don't always last or persist for a long period of time, and generally it's a good idea to look at it at least every hour to 2 hours, but some patients may look at it every 30 minutes. It depends on how proactive you'd like to be. So again, at some point the shelf ends, and so it's good to always look back over time. You don't want to always change your basal rates, whether it's a pump or your long-acting insulin injection, unless you're seeing trends that last over several days, over long periods of time when you have not been eating. So in this example here, you can see that the bottom image, that the patient is getting too much insulin or basal insulin or long-acting insulin overnight. So the patient is going to bed with a certain value, let's say around 140 in this example. If you look back over time, over several days, and you keep noticing a trend where you start at 140 and you end in the 70s or 60s, even though you're in the normal range, that's too big of a drop over time. Because remember, a shelf is plus or minus 20 or 30 points, where in this example, the patient is dropping much more than that. So even though it's a normal range, you run the risk of having low sugar not only in the middle of the night, but it'll also affect your ability to properly microcarb or give yourself corrections of insulin during the day too. So it's important to look back over time during periods of shelves to make sure, especially overnight, from bedtime to the morning, to make sure you have a relatively flat period of sugars so that you can define your basals properly and give your basal insulin at a right dose. Remember, the basal insulin dose is to keep your sugars flat over a period of time, and the best way to look at that is overnight. But it can also be seen in the day. So inflection, you can inflect or adjust these shelves up or down based on a situation. So the concept of taking a drop is shown here. A patient is around 200 in the top image, and they gave a few units, 6 units of insulin. there's a little bit of a lag time and then the sugars start to drop. And so you, again, patience is key. You want to give it some time and then see if you flatten out. Um, Nudging the shelf is another concept, and is moving the trend line a little bit. So again, these maneuvers that you're going to be doing, where you're either giving yourself a little bit of carbohydrates or giving yourself a little bit of insulin, have rely a lot on the fact that you want to have a steady basal rate of insulin, or basal neutrality, which is that concept of looking back over time, making sure that your basal insulins leave your sugars flat over long periods of time if you're not eating, and if there's not a lot of stress at the same time. So you want to watch a delta wave, meaning the blood sugar is rising on the way up, if it's under your target blood sugars. So in these examples, it depends on your target. So some patients may need higher targets, some patients may need lower targets, and you have to make a decision whether to use activity, exercise, or insulin to bring the sugars down. So you can deflect or pivot a delta wave if it's above your target sugar. So in this example, the patient is rising, they waited long enough, and they're seeing that it's risen, they can give themselves a small amount of insulin and bring the sugar down. And that's what a basic pivot would be. Now, as you get more experienced, you can treat a rising blood sugar after a meal, even when you're not eating, and so we call those non-meal corrections, and give yourself smaller amounts of insulin and then wait and see what happens. So you can deflect your delta waves in stages. So as you're watching the sugar rise, you can give yourself, in this example, 3 units of Humalog and see if it works. Give yourself some time. You see that you've reached a shelf, but you're still not in the target range of this example, even after about 30 minutes to 40 minutes. And this patient gives themselves another hour or two later, they give themselves another 3 units of Humalog to bring themselves down into the target range that they've defined for themselves. So this example would be a double tap pivot. And you also want to know how to recognize and react to blood sugar inflections. So again, I strongly recommend all patients read this book. It is a little technical, but it's important if you're going to use a continuous glucose monitor to know what to do with the information. In this example, in the background, you see this reddish curve, and this is referring to, so this is going to give you some examples of what you could do with the information. This red area is defining a slow-acting carbohydrate meal that has quite a bit of fat and protein. And so the patient started eating around 6 p.m. here, but the effect of the blood sugar, of the meal and the blood sugar is slow and doesn't peak immediately. So you don't have to dose all your insulin for a meal up front. So you can give, in this example, they've given themselves a few units of insulin, 7 units of insulin at the beginning, even when their blood sugars are normal. So so that they can counteract the effect, because they know this fatty meal will have an effect later, and you don't want to let the sugars rise too quickly ahead of time. So you'll dose rapid-acting insulin while the blood sugar is still in range. And remember, with this continuous meter, you'll at least be able to quickly identify if you're about to have a low or a high. So you'd want to keep glancing back and deciding when or if you should act on the deltas. And in this example, a few hours later, they give themselves a few more units of insulin, and it continues to rise. They had a shelf, and again, they made a decision around 9 p.m. Okay, it's rising again, so they give themselves another 4 units of insulin. And so this is an advanced sugar surfing skill, you could say, but it's important to be able to recognize these inflections and synchronize insulin, food, exercise, to adjust your insulin glucoses over time, because every meal may be different, have a different effect on you depending on the content of that meal. So this is examples of dosing on the deltas over a longer period of time. Then there's a concept of waiting for the bend. So you can wait for an inflection or a pivot to occur before eating. The downward bend is strong evidence that the mealtime insulin is working. So if your meal is delayed until the bend occurs, there's less of a chance of after meal spiking. So basically, you can these short-acting insulins don't work quickly in everybody. So some people maybe 5 minutes, some people maybe 25 minutes. So it depends on each individual, and over time it may change for you. So you would want to give the insulin ahead of the meal if you know you're going to eat, and you don't have to give yourself a ton. You can give yourself just enough to start seeing a bend, and that's the time when you can start to eat. And so there is a window of time to eat a meal during right after the bend occurs, which results in the least amount of rise in blood sugar after a meal is completed. So how long to wait is really dependent on what your lower blood sugar limit is and how quickly the trend line is dropping, and kind of the situation that you're in. But this concept of waiting for the bend prior to eating is a good one. So there are so many more things that a patient can learn from this book, and so I strongly recommend again that this is one of the required readings I have for patients with type 1 diabetes. Patients that are on basal bolus with type 2 and a continuous meter will also benefit from this. I really like this quote that Dr. Ponder has. It says where he says, "Some people say that sugar surfing is too hard. I often respond by saying driving a car has all the decision-making elements of sugar surfing and has a much faster pace. Yet, millions of people are driving cars safely every day." So if you're going to get this device, you need to know a continuous meter. You really need to know how to use the information. So you can purchase this book on Amazon. You can also visit their website at sugarsurfing.com. Thank you for your time.